Bismillahirrahmanirrahim. Now, talking about laryngeal cancer, it is the most common cancer of the upper aerodigestive tract. It has subtypes like glottic cancer, which amounts to about 59% of cases. Supraglottic cancer amounts to 40% of cases, and subglottic cancers 1%. Most subglottic masses are extensions from glottic carcinomas. Risk factors for laryngeal cancer are two most important: smoking and alcohol. In the supraglottis, now we talk about the T staging of the tumors. In the supraglottis, the tumor is limited to one subsite of the supraglottis with normal vocal cord mobility. ET tumors invasion of mucosa or more than one adjacent subsite supraglottis or region outside the supraglottis without fixation of the larynx. Now T3 is tumor limited to the larynx with vocal cord fixation and invasion of postcricoid area or pre-epiglottic tissues. T4 tumor of the supraglottis is invasion through the thyroid cartilage or extension into esophagus or carotid sheath, etc. In the glottis, which is the vocal cord area, the T staging is as follows. T1 is tumor limited to the vocal cord with normal mobility of the vocal cord. T2 is tumor extension to the supraglottis and or supraglottis, subglottis, and impaired vocal cord mobility. T3 is tumor limited to the larynx with vocal cord fixation. And T4 is tumor invasion through the thyroid cartilage or other tissues beyond the larynx. Subglottis is again similar. Tumor T1 is limited to subglottis, T2 is extending to a vocal cord with normal or impaired mobility, T3 is tumor limited to larynx with vocal cord fixation, while T4 tumor is invasion through cricoid or thyroid cartilage or extension to the tissues beyond the larynx. Staging the nodes in TNM classification, NO is no cervical lymph nodes positive. N1 is single ipsilateral lymph node which is less than 3 centimeters. N2A is single ipsilateral node which is more than 3 centimeters but less than 6 centimeters. And N2B is multiple ipsilateral lymph nodes, each less than 6 centimeters. N2C is bilateral or contralateral lymph nodes, each less than 6 centimeters, while N3 is single or multiple lymph nodes more than 6 centimeters. Now, presentation of cancer or carcinoma of the larynx is with hoarseness usually. Most common symptom is hoarseness, where small irregularities in the vocal fold result in voice changes, initial stages, changes of voice in patients with chronic hoarseness from tobacco and alcohol can be difficult to appreciate in the initial stages of cancer of the larynx. Then the other symptoms of carcinoma of the larynx can be with progression of the disease. There can be dysphagia involving the postcricoid area or the esophagus. There can be hemoptysis. There can be throat pain. There can be ear pain, referred otalgia it is called, and airway compromised, like giving rise to dyspnea and stridor, and aspiration problems, and neck masses due to extension to the lymph nodes of the neck. Diagnosis of cancer of the larynx with direct laryngoscopy and biopsy, as well as chest X-ray and CT or MRI. Here's a picture of cancer of the larynx. Here is the supraglottic cancer and these are swollen arytenoid cartilages in the view. Here is a picture of true vocal cords with one vocal cord involved due to the tumor here. And here is a picture of the laryngeal specimen after removal. It's split to show the tumor involving the larynx here. Treatment of carcinoma of the larynx is in the early stages like T1 and T2. It can be treated with radiotherapy or surgery alone, whereas advanced stage lesions often receive surgery with adjuvant radiation. Most T3 and T4 lesions require a total laryngectomy, which is removal of the larynx altogether. Modified or radical sections are indicated in the presence of nodal disease as well to clear the neck from the disease, whereas chemotherapy can be used in addition to irradiation in advanced stage cancers. Thank you very much.